Thank you all for joining us for Grand Rounds today. I have the pleasure of introducing our speaker, Dr. Tamar Taddei. Dr. Taddei completed her medical school and residency training at Georgetown University and a fellowship in gastroenterology at Yale University. She is currently Chief of Gastroenterology at VA Connecticut Healthcare System and Professor of Medicine and Vice Chair of Faculty Development in the section of Digestive Diseases at Yale School of Medicine. Her clinical interests focus on developing systems and programs to deliver outstanding multidisciplinary care to people with cirrhosis and liver cancer. She directs the liver cancer program at VA Connecticut Healthcare System and founded a VA regional tumor board serving Connecticut, Massachusetts, Rhode Island, and Vermont. Her research focuses on outcomes and clinical trials in cirrhosis and liver cancer. She is co-principal investigator of the Veterans Outcomes and Costs Associated with Liver Disease Study Group, the Statins and Cirrhosis, Reducing Events of Decompensation clinical trial, and the Preventing Liver Cancer Mortality Through Imaging with Ultrasound versus MRI clinical trial. Passionate about educating, mentoring, and sponsoring the next generation, Dr. Taddei has been recognized with teaching awards for her dedication to the education and career advancement of medical students, residents, and fellows. She will be speaking to us today on care across the liver disease continuum, practical lessons learned from VA cohort studies, and systems of care. Please join me in welcoming Dr. Taddei.
Sound check. Can you guys hear me okay? All right. Thank you very much for the kind introduction. I'm really honored to be here today to give the Schiff lecture because the Schiff family has had such a legacy in the field of hepatology and obviously here at University of Miami. But it also is special for me to be here because Joan St. Onge is my program director at Georgetown when I was in training. And this June will be my 20th year since the completion of my chief residency. So I have some advice for you at the end of this talk. And I remember coming to Grand Rounds as a medical student and a resident and thinking, wow, will I ever be able to get up there and talk about something with a level of expertise? And 20 years later, I'm happy to say I think I am. So my objectives for you today are really to come away with an understanding of how the VA, which is a learning healthcare system, applies population health data to improve cirrhosis care, to appreciate how VA cohort studies have led to improvements in liver disease and liver cancer care, and to learn about key questions in the field of liver disease, cirrhosis, and the clinical trials that seek to answer them. I think I'm losing my mic, so give me a second. All right. That should be better. So I don't have any disclosures for this talk. I want to start with what is a learning healthcare system. I think we hear a lot about this, but really, what is it? And the Institute of Medicine in 2013 published a monograph about learning healthcare systems and to deliver best care at a lower cost. And this quote really resonates with me, that the foundation for a learning healthcare system is continuous knowledge development, improvement, and application. And although unprecedented levels of information are available, patients and clinicians often lack access to guidance that is relevant, timely, and useful for the circumstances at hand. And I think we're all in this crossroads where we have an information overload and we are struggling with how do we really bring relevant, clinically relevant information to our patients. And you can see in this figure that comes from this monograph that we have really what is a leaky sieve in medicine, where we have great science, but we, really don't manage those insights properly. We have good evidence for changing our clinical practice, but the evidence is poorly used. And we actually deliver great care, but oftentimes we don't capture how we're delivering good care and how we're implementing care delivery, which, affects the patient experience from the bench all the way to the bedside with lots of missed opportunities, waste, and harm. So the Institute of Medicine in this monograph made recommendations for learning healthcare systems, and they stress three big pillars. The first is foundational elements, so having a digital infrastructure and really data utility, being able to manage and access and analyze your data, to really improve care by using clinical decision support systems, practicing patient-centered care, having strong linkages to the community, really developing a pipeline for continuity after linkage, and also optimized operations. How do we really streamline our operations? And then having a supportive policy environment. So there should be financial incentives for people to deliver best care. There should be performance transparency where you actually have audit feedback on the care you're delivering. And there should be broad leadership that's invested in this type of endeavor. So I'm going to give you a little background about the VA. I know that you're affiliated with the VA across the street, and clearly the VA has been a huge healthcare system that's delivered a lot of great science to the United States, but you may not know its structure. So the VA consists of 18 VISTA integrated service networks. VISTA is essentially our data, where our electronic health record. You probably are used to using something called CPRS, but CPRS is just the user interface of VISTA. And we have about 9 million veterans receiving care at the VA, and that number fluctuates over time. It's essentially, we're always recruiting new veterans into care, and we're starting to see younger and younger veterans, but we still have overall an aging population of mostly male patients. And the VA is the single largest provider of liver disease care in the nation. We have a 5-fold prevalence of hepatitis C, 41% of our patients have obesity, and 30% have diabetes, and 11% have current alcohol use disorder. So there are a lot of risk factors for liver disease baked into the VA population, which makes the VA a very unique and rewarding clinical laboratory, if you will, to study liver disease. So how does research at the VA dovetail with clinical practice in a learning healthcare system? So the strategic priorities for VA research are increasing veterans' access to high-quality clinical trials, increasing the substantial real-world impact of VA research, putting VA data to work for veterans, actively promoting diversity, equity, and inclusion within our sphere of influence, and building a community through VA research. So these are the pillars, and you can see that every day at the VA is veteran-centric. You have to walk into the building with the veteran in the forefront of your brain, no matter what you're doing, and you leave the building the same way, which is very nicely mission-driven for people who like to have a solid mission. But what you can see is because the VA actually demands that you write your grants with the veteran in perspective, there has to be a lot of crosstalk between research and clinical practice. What are you going to deliver to the veteran? How is this research clinically relevant? How is it going to change a veteran's life? And so this research practice crosstalk in the VA is highly developed, probably more so than in any other healthcare system. Now, the VA has leveraged research in becoming a learning healthcare system, and they really focus on practice-based research that informs future research so that there's a culture of quality and iterative innovation. The VA performs very large-scale research, combining expertise in implementation science and in health information technology. And because they're a federal agency, they're able to recruit the help of, for example, the Department of Energy to be able to do very, very high-speed computing. They employ rigorous analysis in both quality improvement and independent investigation. So you have a lot of quality improvement initiatives going on at the same time as investigator-initiated studies, where the two can come together to make sure that whatever's found can be implemented quickly. And obviously, they leverage big data with deep data to generate patient and provider-centered metrics. And in the era of AI, we're seeing a lot of this in the VA, the sort of deep data to really understand how we can get the EHR to work for us instead of us working for the EHR, which is the case in most electronic health record systems. So this is a very early slide, about 2 years after what is called the corporate data warehouse was envisioned. And why am I showing you this? It's because basically what happened in the VA is a decision was made that they were going to curate and collect all patient-related data into a warehouse that could be then created into data marts that analysts could use to develop any number of things like population health dashboards, like studies. And so all of us who do VA research, we actually have a computing infrastructure where we get access to a project folder, and we can ask people who work in CDW to pull us a cut of data, and that data can be on any particular population we may be interested in. And this is a service. So this is essentially data as a service that is centrally managed by the VA. And it really opens up a lot of opportunities to do very important research, but also very important quality care and day-to-day operations dashboards for patients. This is a more modern depiction of this, and what's important is sort of the lower half of this depiction. It used to be that you could only get data out of CDW, but now we're actually able to put data back into CDW. This is super important for example, the Million Veteran Program and all the next-gen sequencing we're doing in tumor profiling, that we can actually feed that data back to CDW. So we can identify, for example, populations that may be suitable for a clinical trial. So this has now become a two-way street, which really increases our power to bring very meaningful research and clinical care to patients. So I want to tell you a little bit about a case. This is a real case, and this sort of will touch on population health dashboards. So in 2017, a 63-year-old veteran presented to establish care in the VA after losing his job and his private insurance, which happens a lot. His primary care provider orders a hepatitis C antibody with a reflex viral load per VA policy. And the results show that he's hepatitis C positive and that he has a measurable viral load and he's genotype 1B. And this happens for every new veteran. Every new veteran gets a hepatitis C test. We always do hep C RNA reflex, so we make sure that they're not viremic. And then we have basically ways of linking them to care right away. So he's referred to liver clinic, which is the standard. Basically, they put in a liver consult. In liver clinic, we looked at his labs. His FIB-4 score was 3.95. His liver stiffness measurement by transient elastography was 15.2. And so these two numbers, basically they tell us, yes, he has advanced fibrosis, probably cirrhosis, secondary to HCV. And this is now entered into his problem list as an ICD code. For those of you who may wonder, in the private sector, it may take a long time to get this person specialty care. It's not hard to do that in the VA. And I think in the private sector, this patient could easily get lost. You could ask, well, in the VA, how quickly does he get linked to care? Before I move on, I just want to underscore what is a FIB-4. A FIB-4 is a very easy test to do. Some people have automated FIB-4 scoring in their lab packages. You basically look at a patient's age, their platelet count, their AST and ALT, and then it gives you sort of an idea of where they stand on a fibrosis scale. And really, we're interested in people who have fibrosis that may progress to advanced fibrosis and cirrhosis. And most of us would like to see a patient when they're in that, intermediate area before they get to the high area. So if you're testing for hepatitis C, which you should be, just know that these people do need to be linked to liver care. And that the fibrosis 4 score is now a part of the diabetes guidelines. So basically in anybody who has diabetes, you should be calculating a FIB-4 score. This is new as of July of 23. So in anybody with abnormal liver enzymes, you really ought to be calculating this score, okay? So as part of just bread and butter primary care, think about FIB-4. So to kind of underscore the CDC recommendations, by now you all should be doing universal hep C screening at least once in all adults who are 18 years and older. These guidelines were, date back to about 2012. You shouldn't stop screening in people who have, recognized risk factors and people who ask you for a test. And, you shouldn't ask for disclosure. If they want a hep C test, they should get a hep C test. The management side of the CDC recommendations, I think, are probably pretty onerous for primary care docs. I know many primary care docs have thousands of patients on their panels, and for you to do all of this in a visit could be daunting, which is where I think things like, medical evaluation for chronic liver disease, weight management, healthy diet, active lifestyle, et cetera, you really do want to have some idea of where they sit on a fibrosis spectrum to be able to really counsel them with rigor if they have advanced fibrosis. So a lot of this, I think, is very hard for a primary care doc to do in their daily clinic load. And that's where I think we can help as hepatologists. So how does this person get linked to care? So what happened in 2014 when direct-acting antivirals came to market is that the VA established very quickly and very nimbly for a federal agency an infrastructure, which started from the top down at the central office with hepatologists, lean experts, data analysts, public health partners, to really identify everybody in the VA that had hepatitis C. And what they did is they established something called hepatitis C innovation teams that were in each of the 18 VISNs. And all of those teams were basically attended by one of the stations or centers in the VISN, right? So you're at Miami, the Miami VA is a station in VISN 8, and they had a representative on their HIT team. And basically what it was rapid dissemination of treatment protocols, of note templates, et cetera, to be able to care for these patients immediately, which was, to me, I mean, one of the most rewarding things to witness in my career. I don't know that anything can top it. And one of the things that was part of this was this dashboard. So I pulled this data from my VISN 1, just to show you that as of, I don't know, Sunday, we only have 455 veterans that are viremic in care in VISN 1, which is unbelievable. We're talking 455 patients, right? Whereas you can't see this in the private sector. So we've all but eliminated hepatitis C. And what you can see is that we also can drill down to the patient level. So we can write back to this dashboard with things that might be barriers to care. Do they have unstable housing? Do they have issues with transportation? Why aren't they in care? And so now we know in the VA that really it's about 20,000 patients that have tremendous barriers to get their treatment, but the rest have been treated. And this startling figure shows that we have really moved the needle. Right now, you can see that we've treated almost all of our veterans with only about 20,000 awaiting treatment. That amounts to 200,000 veterans over 20 years, but obviously the vast majority of these veterans were treated since 2014 and the advent of direct-acting antiviral therapies. So we've done probably 120,000 cures in the VA. So how does that compare to the private sector? And you can see that the private sector is lagging way behind. So there's about 1.7 million Americans or US citizens or US residing people who have a positive hepatitis C antibody. So they definitely have been exposed to the virus, right? There's probably an estimated million more that have never been treated. Or never been tested, so they don't even know if they have it. So estimates range between 2.4 million and 2.7 million across the US, and we know of about 1.7 million. Now, only 88% have actually had viral testing, so the sort of reflex to say, yes, you're viremic or not. Of those 88%, 69% actually have a measurable viral load, which is about right. Hep C can be spontaneously cleared. And of this group, only 34% have been cured or cleared their virus. So this is pretty sad. We have a long way to go. And thankfully, Francis Collins is doing a lot to try to eliminate hepatitis C in the US, because at this point we have cure. We have like 98% chance of cure with anywhere from an 8 to 12 week regimen. It would be ridiculous not to do this for the whole population. So getting back to this case, our veteran is, now it's 2022, and our veteran's 68, right? It's 5 years later. His hep C was treated with direct-acting antiviral therapy in 2017, and he attained sustained virologic response, which is a cure, essentially. And he's since put on weight, and he's developed insulin resistance, as a lot of people do as they age. So remember that just because you eliminate one factor that could be causing hepatic fibrosis, you're not eliminating the other factors. And actually, aging in and of itself is a fibrotic endeavor. We know that from our arteries and hypertension, right? But it happens in the liver too. So his FIB4 is now 5.43. His AFP is 7. So what advice can we offer him about his risk of liver cancer? And this is very important. I want to give you a little bit of background around liver cancer, because I think we often forget to screen our patients for liver cancer. Even if we know they've had cirrhosis, somehow or other they fall off our radar. And my hope today is, if there's anything you'll come away with, it's to test and treat hepatitis C and screen for liver cancer in the appropriate patients. So HCC is a leading cause of liver-related and cancer-related mortality. It's the leading cause of death and cirrhosis. It's the third leading cause of cancer-related deaths worldwide. So in 2020, over 800,000 people died of HCC across the globe, and a predicted 1.3 million people could die from liver cancer by 2040. This is a big problem. It's getting worse. Chronic liver disease is a prerequisite in probably over 90% of cases, and these are usually viral hepatitides, alcohol-related liver disease, or the new nomenclature, metabolic-associated steatotic liver disease, which replaces fatty liver disease. And the HCC incidence tripled in the US from 1990 to 2020. And that was the aging cohort of people who had hep C and had their fibrosis basically progressing over a 20, 30-year period. Now we've actually seen a slight decline, but the problem is this epidemic of obesity and fatty liver disease, which we think will now start to see our numbers rise as the rest of the globe predicts as well. So who should get surveillance? Now, screening and surveillance, those are terms that are semantics depending upon what culture or specialty you're in. I'm going to use them interchangeably. Surveillance is meant for an at-risk population, and these people are at risk, so surveillance is the proper term. But we use screening a lot because we're screening for an event, right? And a lot of oncologists prefer that term because surveillance means you're actually performing surveillance in somebody who has a cancer. But here we're really talking from an oncologic perspective about screening for a cancer, right? It just so happens this is an at-risk group. So we recommend a liver ultrasound and AFP every 6 months in all patients with cirrhosis and in patients with chronic hepatitis B. Hepatitis B is a carcinogen. The virus itself actually intercalates into the host genome and is known to be oncogenic. I'm not going to talk about hepatitis B today, but generally speaking, those people can develop HCC in the absence of cirrhosis, so they do need to be screened. These guidelines are actually from all GI and liver specialty societies across the globe. They haven't really found a footing in primary care guidelines, which is a problem. So once you have a lesion on ultrasound, you really do need to think about what comes next. And so if that lesion is visible on ultrasound and less than a centimeter, you can repeat an ultrasound in 3 months to look for growth. If that lesion is equal to or greater than a centimeter, or the AFP is at or above 20, you'd really want to go directly to dynamic contrast enhanced CT or MRI to rule out a liver cancer. So this algorithm is pretty cookie cutter, pretty simple. There are some gray areas, however. Patients with Child-Pugh C cirrhosis who are not transplant candidates, these are people who already have end-stage liver disease with a life-limiting, pretty significant life-limiting liver disease. They're not going to benefit from a cancer diagnosis, but you first need to make sure that they're not transplant candidates. Because if they're transplant candidates, they need to be assessed for transplant. And then, of course, MASLD without cirrhosis, this big population that we're seeing more and more of, they can actually develop liver cancer in the absence of cirrhosis, which keeps us up at night, but we don't have enough biomarkers to know who we should be screening. So this group remains in the gray area. And then in patients who've actually attained a cure of their hepatitis C, but didn't start with cirrhosis, we're not really sure at what point their risk falls off. And so we're not sure what to do with this group. And a lot of studies are going on in these gray areas to understand more, especially in biomarker development. So HCC surveillance saves lives. And this is a meta-analysis of about 150,000 patients, which was published recently. And you can see that all the parameters of what would lead to greater survival are met with pretty good odds ratios. So essentially, early stage detection, receipt of curative therapy, and overall survival. We know that surveillance saves lives. The issue is that it's never really been shown in a very rigorous randomized controlled trial with a non-screening arm. And I would beg to say that you don't jump out of a plane without a parachute, right? That's not ever going to be a randomized controlled trial. And so I think there's an issue now where ethically a lot of people wouldn't want to participate in a non-screening trial or arm of a trial, and I will get to that a little bit later in my talk. There's still not a lot of understanding around the harms of screening, and so there's a lot of studies going on about what are the harms. How many times are you going to call something that needs a biopsy and the person could bleed to death, for example? What are the psychological harms of having to get a test every 6 months? These are studies that are ongoing. So surveillance rates, however, are very poor. So even in the VA, they're poor by international standards. So I wanted to just show you a private sector cohort. So this is a Hep C cirrhotic cohort in a big tertiary care area. And you can see that proper surveillance conducted every 6 months was only done in a quarter of patients. And maybe people got some imaging, every 12 months, but for the most part, it was subpar. And in national VA data, and this is looking at essentially every station in the country, we hit about 44%. So you can see that we are better than the private sector, but we really come far below some international standards. So in the UK, for example, they screen 65% of patients. They have about a 40% 5-year survival. In Japan, they screen 75% of patients, and they have a 50% 5-year survival. And in the US, we have a 20% 5-year survival. That's been static for a very long time. And the reason is we simply are not doing what we need to do to reach a threshold that are going to have the survival benefit of screening. So we only see that tip of the iceberg, right? So linkage to liver care and liver cancer care starts with identifying cirrhosis and starting surveillance. So this undiagnosed cirrhosis group, the sort of base of the iceberg, is in your clinic, okay? These are people who have diabetes, who are overweight, who drink too much, who have any number of risk factors that put them at risk for developing advanced fibrosis, cirrhosis, liver cancer, et cetera. And the problem is that it's mostly a silent disease until it declares itself, and then it declares itself and you're on the wards taking care of somebody who is really, really sick really quick. And I would say that thankfully with the American Diabetes Association putting FIB-4 into their guidelines, perhaps we'll detect more of these patients earlier, but this really has to be a primary care effort. You have to think about liver disease and about cirrhosis. You have to look at albumin over time. You have to look at platelets over time. You have to trend those values. So just because you're seeing that patient for that moment in time, you have a bevy of data. Wouldn't it be great if there would be some platform that could show you that data, right? Trended over time right in front of you. So primary care providers need to be educated to suspect cirrhosis, especially since up to 1/3 of Americans are at risk. And of course, HCC surveillance needs a mandate, but I don't think it'll get one until there's a reasonable study that shows without a doubt that there is a benefit to survival. So VA observational cohort studies have taught us a lot about HCC and about liver disease and about team science. So here I show my co-PI, Dave Kaplan from the University of Pennsylvania. He and I co-founded the VOCAL study group in 2012. We called this group the Veterans Outcomes and Costs Associated with Liver Disease. And I have to credit David for that because he said, well, every study group needs a catchy title. And I'm not so much about catchy titles, but it's definitely stuck. And the aim really was to describe the burden of liver cancer among patients with cirrhosis in the VA. That was our only aim. And the methods were really this was in 2012 when the CDW was finally taking shape as a curated research data set. And there was this computing infrastructure called Vinci. And we gathered all patients with cirrhosis diagnosis codes from the VA informatics computing and infrastructure. It's called Vinci, essentially. That's where all researchers do their research in the VA. And we abstracted all the charts, meaning brute force went to every single chart, of every person with ICD codes for HCC from 2008 to 2010. That amounted to 7,011 charts, of which 3,988 patients had HCC and were cared for in the VA. That was a lot of work. So we founded this in 2012. We didn't really start publishing until 2015, as you can imagine. And we engaged 8 VA sites to validate an electronic child Turcotte-Pugh score to stratify patients by severity of liver disease. So the Child-Pugh score is a score that we still use today, although it was only developed, 1964, I think. It's been refined over the years, but you can't really study liver disease until you can stratify those patients by the severity of their liver disease. And this is how we were able to do this in an electronic health record. Now, what I want to impart to you is this cohort was actually born of a monthly call to vent clinical frustrations. And, some 12 years later, it's produced over 50 publications and has directly engaged over 30 investigators, including medical students, residents, fellows, and faculty, some of whom are sitting here today. So really, it's good to call your friends. It's good to complain. It's good to build a team, and it's good to solve problems. That's what we're here to do every day. So our early studies showed that specialty care connection, distance to a facility, and appointment lead time really affect HCC surveillance rates. And this is actually work done by Dave Goldberg, who's sitting in the front here. And what he found was that seeing a gastroenterologist or ID specialist within the first year of cirrhosis diagnosis doubled screening adherence rates. That ultrasounds ordered more than 3 months ahead of time were much less likely to be performed. That's a very simple quality improvement to make. and that veterans residing farther away from their local VA medical center had lower rates of surveillance. This was building upon Dr. Goldberg's earlier work in transplant, where clearly distance makes a difference. And you can see here that the more specialty clinic visits you have, the more likely you are to actually approach what is reasonable screening, which would be 2 ultrasounds in a 1-year period. We also found that there were major gaps in HCC treatment. So this study, which was conducted by Marina Serper at UPenn, showed that really about a quarter of patients overall weren't getting any type of liver cancer therapy. Now, we use a different staging classification than the TNM classification you guys are used to, but BCLC0 and BCLC-A disease are very early disease. These are curable cancers. And you can see that 14% of patients weren't even getting treatment for a cancer that's curable, right? So we had to definitely intervene. One of the things that was very interesting in this paper was that she showed obviously the correlation between proportion treated and overall survival, which is an obvious finding, but it didn't really matter whether you were a big VA or a small VA. So these circles, the diameter is based on what the population is of patients being treated in that VA. So smaller VAs did well, larger VAs did horribly, and there were a lot of geographic differences across the VA. And this is something that we've tried to streamline and really make sure that there are metrics in place across the nation. The most startling finding of this paper to me was that hepatology care, while not associated with higher odds of receiving active therapy, was associated with a 30% reduction in mortality. And that means you need a hepatologist to determine what liver patient is right for what treatment, okay? We're sort of the gatekeepers of, is this treatment the right thing for this patient based on the severity of their liver disease and other factors? And it actually did not translate. It was specific to hepatology. So gastroenterologists didn't see the same reduction in mortality, which I mean, obviously is important. We practice a very specialized, area within gastroenterology. So what about our patient? So will curing Hep C reduce his risk? And the answer is a resounding yes. This is work also, observational cohort work done by George Ianu out of the Puget Sound VA. And what he showed within the first couple of years of having DAs on the market was that it really reduces HCC. And so you can see probability free from HCC diagnosis on the y-axis and years after start of Hep C treatment on the x-axis. And you can see that those without cirrhosis who attained cure did very, very well. Those who had cirrhosis who didn't attain an SVR, they really were at quite high risk of developing HCC. Our patient is in the orange. He has cirrhosis. He attained an SVR. He has a substantially reduced risk. Of all comers, though, in this study, they showed that DA-induced SVR is associated with a 71% reduction in HCC risk in those first 2 years. So that's pretty incredible. But we're still in the throes of natural history, right? I mean, DAs have only been out for less than a decade. So what is the natural history of treated Hep C? And you can see that actually people with advanced fibrosis, cirrhosis, they need to remain in surveillance. And this study, which was done with about 4.5 years of follow-up, shows that if you have a DAA-associated cure and a FIB4 greater than or equal to 3.25, your risk never goes below threshold. And certainly, it will in those without significant fibrosis, but we're not sure what happens to them over time. And I'd like to draw your attention to the black lines, which are those who've been treated and cured with interferon in the past. And you can see, especially on the dashed line at the bottom, these were people who got their cure that might have been, 10 years ago. They had a FIB4 score that was not in the cirrhosis range, and yet you can see they're coming up to threshold. Why is that? It's aging, it's insulin resistance, it's obesity, it's all of the things that lead to progressive fibrosis. So don't lose sight of these patients. They still need to be considered. So I'm going to tell you a little bit about informatics work. So what do we do with abnormal imaging? And I want to bring you back to this case to talk about automated identification of abnormal imaging. So in June of 2023, so in just the last 6 months, our veteran's now 69 years old. He continues to come to liver clinic twice a year. He's very diligent about his follow-up. He had a 6-month surveillance ultrasound. It showed no focal mass. And his AFP is 20. So this is problematic. His AFP is 20. It was 7, a couple years or a year ago. To me, this is concerning that he's developing a cancer. And you're in clinic precepting a fellow, or maybe you're the fellow or even the resident, and you order an MRI and then you graduate 3 weeks later. Happens, you guys move on. But who's going to get the results, right? This happens all the time, especially in big academic centers. Who's going to get your results? No one's going to get your results. That's a problem, because what if this guy has a cancer? So in 2009, I assembled a team because I was staying up at night thinking about these patients and the fellows that I was precepting and the fact that they weren't actually turning over their alerts to me. And there was already some very interesting informatics work being done in lung cancer. And of course, lung cancer is usually diagnosed, or at least there's a concern or suspicion on imaging. I said, wow, liver cancer would be great for this kind of thing. And usual fashion, they said, sure, Tamar, you can work on this. You got any money? I said, no, I don't have any money. And they said, well, just apply for a grant. And I was very lucky to get a grant to bring this work at least a couple years along. And then we've been funded for the last, I guess we're going on 15 years now. And this is a system that's developed to actually identify and track cancers, all kinds of cancers, and to facilitate care coordination. So what you can see is in this particular case, this is somebody with an ultrasound of the abdomen. It gets basically shunted to the tracker by virtue of the diagnostic code that the radiologist put, but also we can do this with natural language processing as well. And this allows a care coordinator to get the results, to ascribe follow-up to that patient, and to really have a very sort of high-functioning task coordinator for this patient's linkage to care. So the RN care coordinators receive daily alerts, and patient triage happens regardless of who ordered the exam or for what indication. We find a lot of incidentals, as you can imagine, and I get to sleep at night, which is great. So this is a pretty early study from, it's a pre and post implementation study on this tracking application. And you can see that we actually did move the needle. So from diagnosis to treatment, we reduced that time from 123 days to 87 days. Some of you may be saying, oh my God, if I had a cancer, I'd really want treatment in a much shorter time than 87 days. Again, this was sort of early pre and post. The VA as a whole has gotten that down to about 40 days or so. The oncologic benchmarks in lung cancer are 60 days from diagnosis to treatment. So we are moving the needle over time. So this case bothers me, and it's not the first time I've been bothered by this case. So on his MRI, he had a 1.7 centimeter ill-defined observation in segment 4A, which is high up in the dome of the liver, right sort of under the diaphragm and the rib cage, often missed with ultrasound. The lesion has characteristic features for HCC, which are hypervascular on arterial phase, washout on portal venous phase. HCC is one of the only cancers that we can diagnose by imaging alone. And the mass was missed on ultrasound. So this is what bothers me. And this bothers me a lot. It happens a lot. So could there be a better alternative? So on the slide, each one of the dots represents a study. And you can see there's some pretty wide confidence intervals here. But if you look at all of the different modalities for imaging, for diagnosis at any stage, you could use any of them. But we really want to get early liver cancer, curable liver cancer. And to do that, ultrasound is pretty poor, okay? You have about a 60% sensitivity with ultrasound, and you might add, a little bit with AFP, maybe getting it up to 64, 65%. The problem is that our population is becoming increasingly more obese, and so it's harder and harder to get good quality ultrasounds. And so to really diagnose HCC at earliest stage, you need dynamic contrast enhanced imaging like a CT or an MRI. So could we propose that perhaps we ought to be using different screening modalities? And you can see here how highly sensitive MRI is. So obviously all of these imaging modalities have their pros and cons. An ultrasound's easy, accessible, cost effective. It's lower sensitivity. There's a lot of inter-observer variability. CT scan, much higher sensitivity than ultrasound, but of course there's radiation. It is faster and less expensive than MRI. You still need an IV. And an MRI is super sensitive, but it's expensive, not widely available, and it takes a long time. It's about 45 minutes to do a full liver scan. So what are some emerging innovations? So contrast-enhanced ultrasound is one, although you really only get certain fields of the liver when you use contrast, so it doesn't give you the whole liver. That's a problem. Standardization of reporting is helpful to say, hey, this was a bad read, not the usual reads that you get that the liver is densely echogenic and small lesions might have been missed, and maybe you should consider CT or MRI, an actual visual rating scale. Contrast and radiation dose reduction strategies like low dose lung CT are being considered for liver cancer as well. But the one that I think is most intriguing is abbreviated MRI with shorter imaging times, because you can really do all the important phases in about 15 minutes and get a very high quality scan. So MRI in the VA is very readily available, and it's not one thing that needs a pre-authorization. So we don't do pre-authorizations in the VA. I mean, I know you spend your days doing pre-authorizations. We don't. So we're really the only healthcare system that could study this. So our question was, could earlier detection with abbreviated MRI result in a cancer-related mortality benefit? So the VA Cooperative Studies Program in the suite of the VA Office of Research and Development, they only fund the most ambitious studies. These are large-scale trials that ask fundamental questions that will change practice, and they have their own dedicated coordinating center. We knew that we couldn't do a non-screening arm study. We knew that it wouldn't be palatable to gastroenterologists and hepatologists. They've considered it unethical. They've written papers about this. And also patients have refused to enroll. So we had to sell this as a non-screening arm, as not having a non-screening arm, which was very tough to get that, sort of beyond what most people would think would be a proper randomized controlled trial. We did have the ace in the hole, which is that technology in body habitus has changed over the last 30 years. So there really is now a push to have better imaging modalities for a lot of different cancers, CT for lung cancer being sort of the first real canary in the coal mine. And they actually accepted this grant. So Georgiano out of the Puget Sound VA is my co-chair, and this study is called Preventing Liver Cancer Mortality Through Imaging with Ultrasound versus MRI. It's the premium study. And it's a randomized controlled trial of ultrasound with AFP, which, as I said, is the standard of care, versus abbreviated MRI with AFP every 6 months in patients with cirrhosis who have high risk of HCC. So these are people with FIB4 scores higher than 3.25, at or higher than 3.25. The protocol, if any of you are interested in radiology, you can see that essentially we're doing the arterial and the portal venous phase studies, and we're using contrast, but we're not doing sort of the FAT-SAT and other studies that take a very long time in the scanner. So the whole idea is that we'll get room time down to 10 to 15 minutes. And we are successful. We've already started enrolling and seeing this. And the primary outcome is a cumulative HCC-related mortality at study N. And then a secondary outcome is all-cause mortality. And we'll be screening patients for 8 years. We're powered to detect a reduction in HCC-related mortality of 35%. So 35% in the cancer world is big. And even cancer people were like, are you sure you're going to detect? And if you look at the difference in sensitivity, yes, I think we can detect this degree of reduction in mortality. So Premium is a 9-year study. It's 47 VA medical centers participating. Miami will be participating. You have to have an adequate MRI capacity and access to multidisciplinary liver tumor boards. Why? Because you can't have a study that screens and then you can't link these people to liver cancer care, right? And the priority is given to what the VA calls network of dedicated enrollment sites. This is part of that research portfolio, linking veterans to clinical trials as quickly as possible. So they have these networks around the country. And you can see that we'll be enrolling for 3 years and screening for a total of 8 years, so that if you enrolled in year 1, you'll get 8 years of screening. If you enrolled in year 3, you'll get 5 years of screening. With 4,700 participants, randomized half to abbreviated MRI and half to ultrasound. And generally speaking, our hope is that abbreviated MRI will lead to earlier stage at diagnosis, curative therapy, reduction in HCC-related mortality, such that abbreviated MRI could become the standard of care, obviously, if this is a positive study. And in order for this to be a positive study, we do need to make sure that there are norms and standards of cancer care in these centers where cancers are detected. So the cool thing about Premium is that it will have a bio and image repository with 10 mLs of blood collected at the sites for every 6 months. The blood will be shipped to the Boston VA Central Biorepository for processing. This is the same biorepository that does the Million Veterans Program. And this biorepository is the largest biorepository in the United States. We'll collect digital files of all the screening ultrasounds and abbreviated MRIs for image analysis. And there are many possibilities for both blood and image-based biomarkers. And so spin-off studies are encouraged. So you heard about it here. We'd love to collaborate across the country. You don't necessarily have to be a VA researcher. You just have to find a VA collaborator. So let's wrap up this case. How does his case compare to others in the VA? So he remains well compensated and has excellent performance status. And he's advised by the Multidisciplinary Liver Tumor Board to undergo ablation, which he does. And this is a curative intent therapy that offers a median survival exceeding 5 years. He's 69. He could be a liver transplant candidate, but his tumor is 1.7 centimeters and under threshold for MELD exception points. And because he's 69 and likely will potentially age out before he develops his next tumor, treatment now is the right way to go. So how does his case compare today across the VA? So this was a study that was just recently published where we took a look at the 2,300 people diagnosed with HCC in 2021 across the VA. We did this because we wanted to look at pandemic recovery to see sort of, are people getting treated? Are we actually diagnosing and treating people appropriately? We took a 10% random subsample for chart review. And I think Dr. John remembers doing his chart reviews. I remember doing my chart reviews. And we found that 72% had underlying cirrhosis. 46% still had tumors greater than 2 centimeters at diagnosis, which is, not surprising, but I wish we could detect earlier cancer. You can see that all the things that you'd expect to affect survival are, what we saw in those who had a longer survival. So they were diagnosed at earlier stage, potentially curative treatments were received, and of course, they had to have good functional status or good liver status. One thing that I think is really cool about this study is that the people who were diagnosed in the VA and receiving VA primary care tended to have earlier stage diagnosis and to live longer. And this is really important. I think keeping your care under one roof helps a lot. And these veterans are keeping their care under one roof. So 78% of these cases were discussed at a multidisciplinary tumor board. And what's really gratifying to me is to look back at that paper from 2017, which looked at that 2008 to 2010 cohort that Dr. Serpa wrote. And then it was only 34%. So we have really moved the needle in terms of multidisciplinary care. And that to me is very gratifying to see. So what are my take-home points for you? And thank you for being with me on this journey through this patient's case. So a learning healthcare system requires vision, infrastructure, and transparency. And the VA is one of the only healthcare systems in the US that reports outcomes and gaps in care with transparency. And we get a lot of flack for it. The near eradication for Hep C in the VA is an example of great leadership and teamwork that I think other health systems should emulate. And you should remember to test for Hep C in all adults. Treatment offers a 97% chance of cure. So this is something you really ought to be thinking about in your primary care clinics. People with cirrhosis need to remain in a liver cancer surveillance program, even if their Hep C has been cured. Don't lose these patients. And people with cirrhosis and chronic hepatitis B should have an ultrasound and AFP test every 6 months for liver cancer surveillance. Simple interventions like ordering a test close to the due date affect adherence to survival. And many more low-hanging fruit type studies could be done like this. Automated systems for abnormal results reporting improve timeliness of care. And the Premium study, a trial comparing abbreviated MRI to standard of care ultrasound for HCC screening, may challenge existing practices. And linkage to specialty care is essential for good outcomes for patients with liver disease and liver cancer. So don't forget about us. We're here and we really do want to help. So, I was thinking last night that I was hoping I would see Dr. St. Ange because she actually saved my butt when I was a resident. I got in trouble at M&M, and I was very upset that the surgeons wouldn't take my patient with really horrible infective endocarditis to the OR. And the cardiac surgeon said, well, how did you feel about this case to me after I finished presenting it? And I said, well, I feel like you basically took away my ability to be a doctor. And instead, I was his friend. And I sat by his bedside when he died. And I was told to leave Morning Report, which I did. And I think Dr. St. Ange got a call about this and called me into her office and said, what happened? And I said, well, I just was honest. And she said, you really, I mean, if you're going to be at the VA, you got to watch it. I can only have your back so long. You need to remember that people have feelings. And so they didn't kick me out of the VA, which obviously, ironically, here I am a VA doc, right? So because it's going to be my 20-year anniversary of finishing my chief residency, I wanted to impart some personal wisdom. Before I do that, don't forget to calculate your FIB4, right? Anybody with abnormal liver enzymes, you calculate a FIB4. So my personal take-home points for you are to have gratitude for the privilege of being a physician, because each day dawns with the promise of new connections and new knowledge, and most people don't have jobs like ours. And there's a hierarchy of responsibility in academic medicine, but there should never be a hierarchy of respect. And that statement is taken from Joe Shapiro at Harvard. You should lift others up with sponsorship and mentorship. It's really our duty. This is how we move forward in medicine. And a team is a group of people who have been inspired to think beyond themselves to work together to achieve a dream. So dream big and build your team. Thank you very much.
Thank you, Dr. Taddei. That was a beautiful grand rounds. Both the science and the personal comments at the end were really drove home important issues. We can open it up to some questions, but maybe I could begin by asking you, it's so amazing the power that you have in terms of the data at the VA. And I was wondering, as we look at cirrhosis, and although you make, and others have made great cases for hepatocellular cancer, are there any other comorbidities associated with cirrhosis itself that you were able to find looking at this data? And you mentioned a couple of times about diabetes and obesity worsening the cirrhosis. Is there any evidence of the reverse? Is there any other signals that you see in the data that we need to worry about in terms of effect of cirrhosis?
That's a good question. I mean, I think the interplay between the kidneys and the liver are very important. And the problem is that because such a large population of our patients have diabetes, we often are stuck trying to understand whether they have diabetic nephropathy, whether they're actually getting hepatorenal syndrome. Usually not, because that's sort of a diagnosis of exclusion. But kidney disease is a rate limiting factor for us for many things in liver disease, including imaging, including cancer treatment. And so I would say that for example, in designing this trial, we had to think carefully about kidney function. And so many of our patients have compromised GFRs that we really had to justify why we would be doing MRI in those patients. So I think the other thing is some of our local regional treatments, like TACE, for example, involve dye. And if you have an elderly person with a very borderline creatinine, are you really going to be prolonging their life by, doing this TACE and giving them contrast and potentially tipping them over? So I think for hepatologists, many of us ran from nephrology. We're like, oh, they're too smart. That's too complicated. But we find ourselves actually becoming quasi-nephrologists in this job. I would say that I think in terms of understanding oncogenesis and inflammation, fibrosis and inflammation are intimately linked in many organs, not just the liver. And I think as much as we see diabetes and obesity contributing to cancer, we see that if you can mitigate those risk factors, you can mitigate a lot of downstream heartache. Most of medicine is preventable, at least adult medicine, right?
Dr. Goldberg.
Thank you, Tamar. So, oftentimes, the pain of submitting a paper from the VA is you get some reviewer saying, well, this is not generalizable. It's largely older males. But I guess on the flip side, though, how do you take these findings from the VA and then extrapolate them to, the private sector where we don't have unified EMRs, where people go to 15 healthcare systems that don't talk to each other, where costs and prior auths are such an issue. Like, how do we deal with that? My patient may get an ultrasound at Baptist labs here, and our computer system may not be able to do the NLP or things like that. So what is the sort of way to take the VA, what we learned from the VA, to the private sector?
So that's a great question. I guess there's two answers to that. So as far as the population, I think the best way to do it is validation studies, and many of those studies have been done. For example, we did a lot of modernization of surgical risk prediction, Nadim, and we did that at Penn, and we took that to other large healthcare systems and were able to validate it, and they rang true, women, men, et cetera. So that's the best way from a sort of methodology standpoint. From an EHR standpoint, I think, Epic is bound to have a pretty good data repository. It's going to take time. But they're already working on it. And I think that computing infrastructure to have sort of APIs for capturing outside imaging, they're also coming along. The VA has done a lot of work in care in the community, trying to get those images back. So I think other care systems can learn from the VA. It would be phenomenal if we had a universal EHR. And I think a lot of our patients actually think we do. They're like, well, didn't you see those records? And we're like, not at all. And it took me 5 hours to get them all together, right? So I think actually our patients think we're much farther ahead than we are. But I do know that if the VA is not doing a good job of it, chances are the private sector really isn't doing a good job of it. And I think we need to be the canary in the coal mine for data infrastructure, for quality improvement, for dashboards, so that the private sector can learn from us.
Thank you. I want to acknowledge first the Schiff family for sponsoring today's lecture for the 28th year in a row. So you're in a long line of illustrious hepatologists that have imparted knowledge to us here. I also want to recognize Dr. Gene Schiff, who is the son of the original Dr. Schiff, who's still active, and we're grateful to have him continue to be on our faculty. I want to remind everybody in the audience and those on Zoom to please look in the chat for the CME link and answer those MOC credits as well. Again, I want to thank our speaker for an absolutely outstanding Grand Rounds. It was grand and round in every way you can imagine.
Thank you.
And we're grateful that you were here. Thank you.